Hello, my name is Astrid Macharé, and I'm going to talk about the angiotensin-neprilysin inhibition in acute decompensated heart failure. So, as a definition, we have the angiotensin converting enzyme inhibitors, the ACEs, that have been the cornerstone of treatment of heart failure with reduced ejection fraction for over 2 decades. And inhibition of neprilysin augments vasoactive substances, including natriuretic peptides, which may have multiple advantages effects in chronic heart failure. Sacubitril/valsartan is a first-in-class combined angiotensin receptor neprilysin inhibitor, (ARNI), and its brand name is Entrest.
An angiotensin receptor neprilysin inhibitor. So it's a new class of drugs. Of course, there's only one drug so far in that class, and it's sacubitril/valsartan. Sacubitril/valsartan is essentially a compound that contains both valsartan, which is an angiotensin receptor blocker, we know it well, blocks the AT1 receptor, and sacubitril, which is a prodrug neprilysin inhibitor. They're together in a crystal, essentially.
Okay.
You ingest it, and these come apart into the component parts. So the AT1 receptor blocks, the ARB blocks the AT1 receptor, and sacubitril is then converted, esterified, to sacubitrilat, which is the active form, and that inhibits neprilysin. What is neprilysin? Neprilysin is a ubiquitous enzyme that is responsible for the breakdown of a number of vasoactive peptides, including the biologically active natriuretic peptides, like ANP, BNP, and CNP. So we were talking before about BNP as a marker, and now we remember that BNP is also a hormone that is, as Cheryl said very early in the program, goes up when in the setting of heart failure, and it goes up as a compensation. So what happens is that when you give a neprilysin inhibitor, you both block the renin-angiotensin system and you make natriuretic peptides go up.
Okay.
And so you're doing two things at once.
Do you remove?
Now we have the definition of acute decompensated heart failure. It can be defined as the starting of or gradual onset of the signs or symptoms of heart failure requiring unplanned office visits, emergency visits, or hospitalization, regardless of the underlying precipitant of the exacerbation, pulmonary and systemic congestion due to increased left and right heart filling pressures is a nearly universal finding in the AVHF.
Heart failure. Heart failure is a problem with your heart so that the heart is unable to pump blood so as to maintain the cardiac output. So the heart is weak and is unable to maintain the cardiac output, and that is what is heart failure. There are two types of heart failure. There is a systolic heart failure and there's a diastolic heart failure. So a systolic heart failure is where the pumping activity of the heart is poor, and a diastolic heart failure where the pumping is okay, but the relaxation of the heart is not so good. And that is why these patients will also have a poor cardiac output.
How would a patient with heart failure would present to the emergency department?
Great. So heart failure has several presentations. Obviously, diaphoresis, restlessness, dyspnea, and they usually have a very high systolic blood pressure. When a patient presents with mild heart failure, where patients will have a pretty much normal blood pressure, they will have a long history, maybe a week, 2 weeks, or a month, of not being able to sleep properly or symptoms of orthopnea, symptoms of breathlessness on exertion, nocturnal cough, and they would have signs of systemic congestion.
The investigations for heart failure.
First of all, we need to find out if it's heart failure or not. So you can do a bedside ultrasound. You can look at for a bedside X-ray. You should do an ECG right away. ABG should be performed. A NT-proBNP should be performed, just to rule out any pulmonary cause of respiratory distress.
Sir, how would we manage the patient with acute heart failure?
So assessment of the patient is very important. As we would assess any other patient, we would start assessment with ABC, which is airway. So we talk to the patient, we see if the patient is talking, if the airway is patent. In B, we would like to do SpO2 levels. We would like to check for respiratory rate. We would like to listen to the chest and send an ABG sample to get an idea of hypoxia, PO2 by FiO2 ratio, etc. With C, we would like to do blood pressure, pulse. We'd like to look for capillary refill time, check if there is a skin temperature, do an ECG. Also, we could send some bloods. We put a cannula in and send some bloods away. Next is D, which is disability. So here you look for GCS of this patient and check the RBS level. E for examination or exposure, and you start examining the patient, and that is how you assess the patient. Now, based on your assessment, is your management.
Yeah, it's nice meeting you, and I think it's very informative topic, and it helps lots of people who are working in emergency department.
I hope it does.
Okay, thank you so much.
Now the applications in medicine, we have the sacubitril valsartan is an angiotensin-receptor-neprilysin inhibitor that is indicated for the treatment of patients with symptomatic heart failure with reduced ejection fraction. In the Paradigm heart failure trial, the use of sacubitril valsartan results in a lower risk of death from cardiovascular causes or hospitalization for heart failure than the use of enalapril in this population.
Head-to-head studies. There's the Paradigm HF trial, right, which was a head-to-head trial with an ARNI, which is sacubitril valsartan, versus the ACE inhibitor enalapril. And what did it show? What were the implications?
So Paradigm HF was the largest heart failure trial that we've ever done so far. 8,500 patients randomized to either this ARNI, sacubitril valsartan, or enalapril, which has been considered the gold standard of treatment in heart failure. And Paradigm was actually stopped early by the Data Safety Monitoring Board for overwhelming efficacy because there was a 20% reduction in a composite endpoint of cardiovascular death and heart failure hospitalization, a 20% reduction in cardiovascular death alone, a 16% reduction in all-cause mortality. All of these were highly statistically significant.
Important study, big study.
What
about 30-day
a combination of two medications, sacubitril and valsartan. It came out in 2015 and it's made by Novartis, a humongous drug company. The medication treats heart failure with low pumping function or ejection fraction, and let me show you what I mean here. This video clip shows a very weakly pumping heart. You can see the heart muscles barely moving. And then this clip here shows a normally squeezing heart. So for people with low pumping function, Entresto can be used with the purpose of decreasing the chance of death and decreasing the chance of hospitalization. It has three basic functions which both of the two medications accomplish. It enlarges the arteries or dilates them, which leads to a decrease in blood pressure. This makes the heart work less, and turns out that in general it's a good thing for people with reduced pumping function. It decreases cardiac muscle cell enlargement or hypertrophy and decreases the scarring that can occur around heart muscle cells in the condition of weak heart pumping function. This leads to a decrease in heart muscle stiffness, which turns out to be a good thing. Importantly, it increases the urination of excess fluid and sodium, which has a number of effects. This can decrease swelling, decrease the symptom of out of breath, and also decrease the need for powerful diuretics, which can harm the kidneys, torsemide and furosemide. Dosing is done with 3 different tablet sizes. The first number that you see here, the 24, that's the amount of sacubitril in the pill, and then here 26 is the valsartan amount. It's a twice-a-day medication. The tablets can be cut, which gives a little more flexibility with dosing. The lowest dose is 12/13 twice a day, and the highest dose is generally 97/103 twice a day. It's typically started at a low dose and increased every 2 to 4 weeks, and it can be taken with or without food.
Now we have the pros and cons. As the pros, we have the number of heart-related deaths was lower for people who took the sacubitril valsartan, at least 9% lower than the people who took enalapril alone. People who took it had better overall survival rates than people who took enalapril, and it is also proved to be used in children from ages from 1 year and older who have a certain type of heart failure with symptoms. And the cons, we have that this treatment could cause serious side effects like kidney problems, hyperkalemia, severe allergic reactions, hypotension, and fetal toxicity. As it is a new medication, its cost is higher, and long-term data is unknown.
With any medication. Side effects. Entresto can cause angioedema. That's swelling of the face, the lips, the tongue, the larynx. It happens in 0.5% of patients overall, but it's much more common in black patients, up to 2.5%. Worst case scenario is the larynx. Your voice box gets all swollen up and you can't breathe. So it's a legitimate side effect to worry about. My brother had it once. He was staying with me at my apartment, and I don't know, he's allergic to something there. Don't know what, but he woke up one morning and his lips were all swollen up, and tongue was like, he couldn't talk right. He couldn't talk right. It's pretty scary. Anyway, if that type of thing happens, you need to seek medical care immediately, and then you're off the medication forever, obviously, if that were to happen. It can also cause low blood pressure in 18% of people, so it's quite frequent. We decrease the dose or just ride it out. It can cause high potassium, which is detected on a blood test quite frequently, 12%. Cough happens in 9% of people. If it's significant, we're stuck stopping the medication. Entresto can cause dizziness and then also worsen kidney function, which would lead to a decrease in the dose typically, or possibly a decrease in the patient's diuretic dose. Some other terrible things about Entresto are the cost. It's just amazing. It's $9 a pill if you pay retail, so that's $18 a day. Of course, Novartis has various programs to try and make the medication more affordable for people who don't have great insurance or maybe don't even have insurance, but overall I just find it to be an extremely expensive medicine that really impedes my ability to give it to people. Another crummy thing is the nearly universal drawback of the fact that its effectiveness was proved in a drug company sponsored study. The potential for bias is tremendous, and as we can see, they stopped the trial early because of this overwhelming benefit. When trials are stopped early, the long-term effect of the medication is less well known, which is the number 3 item here on this list. Really, what happens to somebody who takes Entresto for 10 years? Nobody could tell you for sure. It hasn't been tested that way. Okay.
Now the issue applied in Ecuador. In Ecuador, heart disease affects approximately 1.4 million people, which represents the 14% of the adult population, and heart failure took special importance, since it stands out among the 4 most prevalent heart diseases, with almost 200,000 people. Currently, only select patients can receive the sacubitril valsartan during hospitalization. And finally, in conclusion, among patients who were hospitalized for acute decompensated heart failure, the initiation of sacubitril valsartan therapy results in a significantly greater reduction in the NT-proBNP concentration than in enalapril therapy. There were no significant differences between the sacubitril valsartan group and the enalapril group with regard to rates of renal insufficiency, hyperkalemia, symptomatic hypertension, and angioedema. These are my references, and thank you so much for watching.